Kayla, good afternoon, good morning, good evening, everyone, depending on where in the world you are, and welcome to Continuous Quality Improvement in a Health System, the first in a series of sponsored by the Local Health System Sustainability Project, or LHSS. That's USAID's flagship initiative in integrated health systems strengthening. Our goal is to help low and middle income countries transition to sustainable, self-financed health systems as a means to support access to UHC, universal health coverage. The LHSS project is led by APT Associates. So with that aside, we will get into it here today. The objectives for our webinar are to reveal findings from literature, from a literature review and country experience survey to provide details on current practices in national quality policy and strategy development. We're also aiming to describe best practices and continuous quality improvement learning health system and how these activities relate to other elements of an NQPS, knowing that everything is really tied together, leading towards that ultimate goal of a sustainable NQPS. We're also will share experiences from a leading country who has demonstrated success in establishing systems to support continuous quality improvement within their health system. So some bold objectives here for us today, and thank you for being all with us as we work to achieve these through our webinar. The way that we're going to address those objectives is with our experienced faculty panel that we have here on the screen. First, we will have Dr. Soji Tete, a Vice President at the Institute for Health Improvement, talk about the National Quality Policy and Strategy Framework, which has 9 different elements to it. Of course, positioning continuous quality improvement within the other elements of the NQPS framework. We then have Morgan Stanzler, a research associate at IHI with us to discuss findings from a governance of quality survey that we had distributed earlier this year. We'll then move into the 2 presentations where we'll spend the majority of our time today. We have Dr. Malangizo Mbewe, the Acting Director of Quality Management in the Ministry of Health in Malawi. He's going to discuss continuous quality improvement in Malawi, what it's like there, how they've taken and made the sort of theory around learning health systems and continuous quality improvement real in the country of Malawi. We'll then pass it to Dr. Pierre Barker, the Chief Scientific Officer at the Institute for Healthcare Improvement, who's going to discuss promising practices in establishing a learning health system. So really kind of teasing out some of the lessons from Dr. Mbewe's presentation. After each of our faculty members present individually, we will move into a panel discussion where we'll address any questions that have been raised throughout the course of the webinar in the chat function, or we'll, of course, take new questions as they come in during that time. So as we get started, to direct your attention over to the right-hand side of the screen where a poll should have just popped up for you. We'd like to know your country of origin, where you're joining from today, and then how familiar you are with continuous quality improvement approaches to help us get a sense of experience in the room. So if you could take that poll as we kick off here, that would be great. And with that, I will pass it over to Soji Tete to get us started today. Over to you, Soji.
Thanks a lot, Jesse. To put this entire webinar into some context, I would like to shed some light on the methodological lenses used for the global survey that we'll be sharing today. You've alluded to the National Quality Policy and Strategy Framework proposed by the WHO. That framework served as our foundational framework with 8 elements that highlighted to move on to the next slide. The governance and organizational structures at multiple levels with clearly defined levels of accountability. It also called for the quality policy and strategy of each country to be aligned with the existing national health priorities, so that's not a standalone. The NQPS framework proposed by WHO also advocated for a local definition of quality by national authorities in consultation with the providers and users of care, based on a solid situational analysis of the state of quality, and then through active engagement with stakeholders, including the users and the communities. At all levels, The framework also advocated for improvement methods and interventions that target the system environment, that reduce harm, improve clinical care, and engages and empowers the patients, families, and their communities. And then, of course, there was the important role of data that was called out, where the NQPS framework called for the health management information systems, data systems, quality indicators, and core measures to support the definition of a coherent quality indicator framework that is really adapted to the local context and allows providers and communities to assess progress across all levels of the healthcare system and allows data to drive policy, decision-making, and improvement. So once we use these 8 elements at the base, we then decided to view them through the lenses of other quality governance frameworks. And there's some work that has been done on the health finance and governance projects led by AP, for example, and then IHI's own work supporting ministries of health to develop and implement quality strategies. We view the 8 elements through the lenses of the Durand triad of quality planning, quality assurance, and quality improvement to ensure that we had a comprehensive view of all the efforts needed for ensuring quality health systems. And after this, we propose 2 additional elements that are critical for countries as they develop and implement their national quality policies and strategies. Now, these 2 elements are firstly financing for quality, which really looks at development of costed financial strategy to support the implementation of any national quality policy and strategy, and also looked at the existence of a variety of market-oriented approaches that purchasers can use to incentivize and affect the provision of quality healthcare. The second proposal had to do with the culture of continuous quality improvement, which really emphasizes a learning culture that highlights the role of leaders and managers to create a mission-driven and transparent culture where managers and the frontline staff are safe to self-report incidents of harm and error while remaining open to feedback, especially from patients and their families. On this matter of the culture of continuous quality improvement, we are truly honored to learn from our colleagues from Malawi. And with that, I will hand over back to Jesse to lead us through the rest of the session. Thank you.
Thank you very much, Soji. Hopefully that positions continuous quality improvement within this whole ecosystem of NQPS development. We'll now transition over to Morgan Stanzler, who's going to review findings from a governance of quality survey and literature review that she and colleagues had conducted earlier this year, really trying to illustrate the gap that exists between sort of phenomenal performance and where some of us are today. So Morgan, over to you.
Thank you, Jesse. I'm really excited to share what we found with the preliminary data collection. Next slide, please. So we collected data from 2 different sources. Initially, we did a literature scan of existing primary and secondary data to get a high-level synopsis of what the current state of quality performance is in our priority countries. So we looked at documents like the National Health Sector Strategic Plans, the National Quality Strategies, WHO, OECD survey reports, and so on in 39 different countries. As a complement to that, we also developed and deployed an online survey to further explore what the current state of quality was within each country. This was sent to national level and MOH level individuals from the priority countries to better understand their perspective and experiences developing and deploying their national quality strategies. Next slide. So what did we find out? We found out quite a bit. As part of the literature review, only 2 countries, which were Mozambique and Liberia, specifically included a direct reference to continuous quality improvement and included strategic objectives about how to create an environment for CQI. Some of their ideas were deploying quality improvement training in their front lines, as well as leadership training to help create a culture, a blame-free culture. A few of the countries that were included did have some elements of CQI embedded in their monitoring and evaluation plans, their staff reporting policies, or in their patient satisfaction data and how it was used, but it was not specifically cited as a priority, and most countries didn't really address CQI in any capacity. As part of our survey, most respondents felt that a culture of continuous quality improvement was still more aspirational than actual, but they did have some optimism for how they could get there. They said the most effective strategies came from leaders and fostered trust, transparency, and learning. And there was support to the statement that leadership that promoted a participatory learning system that engaged stakeholders in identifying opportunities for improvement, and that had processes in place to facilitate regular review of staff feedback were most successful. The key challenges that were described to promoting a culture of CQI really started with having a limited understanding of what CQI was and how to effectively deploy the change management strategies among health sector leadership. They also mentioned trying to work within a regulatory environment that reinforces a fear of sanctions was a challenge to creating a blame-free culture. So all of this data is already being used to inform qualitative interviews in some case study countries, and we're really hoping to better understand the key facilitators of success, the most pressing challenges, and how to address them. And that's it from me. Thank you.
Thank you so much, Morgan. So more to come on our findings from that Governance of Quality survey, but it is through that survey that we were able to identify what we would consider one of the leading countries around continuous quality improvement within a learning health system, being Malawi. I think you'll hear throughout Dr. Mbewe's presentation some different elements of the kind of key factors for success that Morgan mentioned, as well as some unique ways that they've been able to mitigate some of the challenges that Morgan also mentioned there. So without any further ado, I will pass it to Dr. Mbewe. Over to you.
Thank you so much, Jesse. I'm going to present on the Malawi experience in setting up quality management structures to improve quality of care as one of the key health system strengthening program in the country. So this is my outline. I will talk about the background, strategic documents, key priority areas which we are focusing, the structures which we have, and the model which we are championing, and also some quality of care framework, also how we are getting the experience of care from the patients through the hospital ombudsman platform, as well as in lessons so far which we have read. So as a background, Malawi is among the countries in the sub-Saharan Africa, and has about 19 million in terms of population, and life expectancy is around 64 years. In terms of health systems levels of care, we have primary, which are mainly health centers, secondary, which are mainly district hospitals and community hospitals, and then tertiary hospitals, which mainly are central hospitals. And as a local government where districts belong. And largely, in terms of financing, is both the government as well as development partners supporting the health sector. And the services are free of care at the point of care. And we have a department, the Quality Management Department, which was established in 2016, which provides strategic leadership and coordinate quality management initiatives across the sector. And basically, in terms of the department is relatively new, and it was established after a review of the National Health Strategic Plan to show that we still have got issues to do with quality of care. And just an example, we looked at, for example, our skilled birth attendance being at 90%, and the versus high mortality rate of 439 per 1,000 lives birth. So when we compare these figures, we thought, I think there are still issues to do with quality, which I think as a country we need to focus. And we are now implementing a new strategic plan, which is running from 2017 to 2022, focusing on universal coverage of quality, equitable, and affordable care. We in terms of having the program of quality in place, we needed to have some strategic documents developed. So apart from the National Health Sector Strategic Plan, we as a country, we developed National Quality Management Policy and Strategy in the same year from 2017. And also we have been focusing more on, as a start, on maternal and newborn health. So we had the quality of care roadmap, which was also developed, and the followed up a mentorship guideline, a manual, and also a Malawi quality improvement training manual throughout the same years. And also WHO developed generic quality of care standards for maternal and newborn health. As a country, we are among the quality of care network where 11 countries are part of, and we did adapt the WHO quality of care standards to our own MNH quality of care standards, and we extended to also develop pediatric quality of care standards as well as assessment tool. And in terms of patient experience, we have developed a hospital ombudsman handbook, which guide officers who are performing this task to guide them in their roles. And we also did a review of infection prevention and water and sanitation guidelines. Just to give a highlight of some of the key issues in our policy, still quality is a cross-cutting issue. So we are focusing on leadership and governance and accountability, human resource for health, clinical practice, client safety, patient-centered care, support systems, and evidence-based decision-making. Just to dig more on this, in terms of leadership and governance, we are really focusing on effective leadership and governance structures at all levels. On human resource, we are looking at having our focus to have adequate numbers with right competencies. And in terms of clinical practice, actually we are waiting as a country to have a national accreditation program for health facilities. And under client safety, we are focusing more on improving infection prevention and control, and water and sanitation and hygiene, as well as patient safety in general. And people-centered care, our focus is on client satisfaction, client satisfaction services, and that's where the hospital ombudsman platform falls with other tools which we have developed to assess on client satisfaction. And on support systems, we are focusing more on infrastructure, including equipment, medicine, as well as even issues of internet connectivity. And on evidence-based, we are focusing on use of quality information for decision making. This is just an illustration of the structures which, as a country, we have put in place. So we have got the national level where we have the Secretary for Health, who is our controlling officer, or the head of the sector, and he is a member of the health sector or the chair of health sector working group, which is a group of donors helping in the sector. And under that, we have the departments where the quality management departments belong. And the department basically has got 3 divisions, that of standards and norms, quality improvement, quality assurance, and of course, digital health. But now administratively, digital health is under a planning department. And we have, as I've mentioned, at levels of care, we have central hospitals. So under central hospitals, we also have got central hospital management team, and under that we have got like a central hospital management section, which is focusing on quality, which is called a quality management unit with the focal person, and within the facility there's a quality improvement support teams. So this structure basically it is cross-cutting in all other health facilities, starting from the district hospitals and other community and health center level, where we have these quality improvement support teams. And within each hospital, under each section, for example, if we are looking at the internal medicine, obstetrics and gynecology, there is a work improvement team, which is the implementing unit for quality initiatives. So the quality improvement support teams, it acts as to oversee, to provide coordination and lead in terms of quality initiatives at each and every facility. I mentioned about Malawi quality improvement model. This is the model which, as a country, we agreed with all the stakeholders to be championing in terms of quality. So if you look at this model, it has got the 5 A's. The 5 A's we are looking at we adapted from the Japanese model 5 A's Kaizen, where the first S is sorting, second setting, the third is sign, fourth is standardizing, then the fifth one is sustain. So we are really focusing, emphasizing this at the first level or at the world level or a unit level to improve the work environment. So it's focusing mainly on improving the work environment. And then the next level, we have like continuous quality improvement, which focus mainly on patient care. And under this continuous quality improvement, we are using the model of improvement as our model, and the main basic tool is the PDSA under this. And our aim is that when this culture and all our facilities or all our departments are able to implement this, and then we will be able to synergize everything, we should be able to have what we call total quality management to be achieved. We hope in the end that we will be able to improve the quality of healthcare services in the country. So this is basically in brief our model of improvement as a country. So using this model, we have been conducting several trainings to build on the capacities of the structures. I mentioned earlier, as well as the health workers, and using the model. So this is just an example of the trainings which so far we have been conducting. And after these trainings, an assessment basically, both self or facility assessment or external assessment is done, where now the facilities or team identify areas of improvement and they start working on improving those areas using QI projects. And at intervals, we do invite facilities to collaborative learning sessions to share what lessons are they learning in terms of the quality improvement projects which are implementing at various facilities, and also that they can learn from each other. The whole aim is to institute the culture of continuous improvement. And within that, we also have got a component of supportive supervision as well as mentorship. And we visit facilities to support them on the areas where they have got issues, and also learn from them if there are any other areas which they need to understand more, and also to check if indeed there is adherence to the standards set by the government. I mentioned about in terms of how we are working on issues to improve experience of care. We have what we call the Hospital Ombudsman platform. This is more or less like a grievance redress mechanism or a complaint handling mechanism. So it focused mainly on community feedback, and the information basically comes from walk-in patients through suggestion box, routine client survey or exit interviews, and the information which is gathered actually is linked to the quality improvement support teams as well as the management of the facility, so that they should take the issues and incorporate them as they are improving the care at their facility. And basically, the people who are taken as appointed as hospital ombudsman, they are the people from the administration, and in other lower facilities where we don't have like administration, often we use the community health worker. We are trying as much as possible to use the people who are not really hands-on in the provision of the actual care, so that people are also free to be able to send their issues to the concerned people. And this program basically is run in collaboration with the National Office of the Hospital Ombudsman, which was approved by enactment in the Parliament. And our long term is to have like established positions for these officers. In terms of lessons, so far we have seen that improving quality of care requires investments, a lot of investments in inputs. More especially, we're also looking at gaps in systems like infrastructure, infection prevention, wash facility, resource system, medical equipment, supplies, and it requires really to look at the issues in terms of funding from the government side as well as also from the donor side in terms of making sure we help us to improve on this inputs which require investments. And we also have noted that we still have got some challenges in terms of conceptualization of some PI processes and tools by our health workers. So this really we have seen that there's need for us to have a systematic quality improvement mentorship as well as led PA learning, so that this is really taken and be the culture. There should be a culture of quality improvement among our health workers. And also linking of quality improvement mentorship with the clinical mentorship so that they synergize and make sure that the improvements are having the actual effects of the improvements. In low income, middle income countries like Malawi, you could do some exit interview and you could see some satisfaction levels from our clients, but I think we have seen that really does not necessarily that is high quality of care. Actually, a lot has to be done on this. And also, I've mentioned about the hospital ombudsman platform, which now want to make it a full-time staff for effectiveness as well as independence. The other area is measuring quality is not easy, more especially if we are looking at what measures do we need to routinely collect and measure, like routine data collection, in the routine data collection like the DHIS tool. So this is also an area which we are looking forward actually to work towards and strengthen that. Currently, the focus is more on maternal and newborn health, HIV, but we are moving towards having a holistic approach to cover all the service areas. And Malawi is not spared about COVID. We have seen also disruption quite a lot due to COVID and quality improvement initiatives such as meetings and other improvement projects which the team started. But we are trying also to see how best we can use the virtual meetings to improve on this area. I think up to this time, I would like to hand over to Jesse. I think thank you so much. This was my presentation from my Malawi as a country experience. Thank you so much.
Thank you very much, Dr. Mbewe, for so transparently sharing your successes as well as your challenges there. We did have a couple of questions coming through the chat that I'll hold till the panel discussion. So right now I'd like to transition over to Pierre Barker, who is going to talk us through a bit kind of promising practice for for promising practices for continuous quality improvement within a learning healthcare system, pulling out some of kind of the key lessons from Dr. Mbewe's presentation. So Pierre, over to you.
Thank you very much, Jesse, and welcome everybody. Really wonderful to be with you. And special thanks to Dr. Mbewe for that really remarkable presentation about how Malawi has really embraced improvement science, and just so much to show for it. So thank you so much, and lots to reflect on there in your closing comments. So what I wanted to do is just to spend a few minutes talking about the essential concept of learning systems. So starting off with this, with what I think may be familiar to a number of you, which is what we call the model for improvement, which really gets at the central questions that we're asking as we try to navigate a learning system. So the big advantage of taking the learning approach is that it first of all helps us with a very clear focus. The health systems tend to be chaotic, complex systems, but distilling true norths and real priorities for countries as they set off to establish their quality goals based on the information that's available is an absolutely essential piece of that. We often, when we speak with governments and other large health systems, one of the first things is just understanding really what it is that's important to try to achieve within a certain period of time. The second major feature for learning systems is really situational awareness. Do we really have the data that we need to tell us whether our system is performing well, and especially whether the efforts that we're throwing at that problem are making a difference? So that would be the second. And the third is, where do we get the ideas from for improvement? And if we're restricting our ideas just to the planning department or to the high levels of the system, we're missing out on all the information that could be coming to us about learning that comes from the front line. So how do we create a system that is able to harvest those ideas from the front line and bring them up so that we can try them out? And that trying out is the Plan, Do, Study, Act system, the rapid cycle, and there are many versions of them that you will have seen that say every idea is not a great idea, but we need to try them out. So these are the three essential tenets: the focus, the situational awareness, and our ability to get ideas, and then a test system to make sure that in our daily work, whether it's 5S or CQI, that there is some way of putting ideas to the test and knowing whether they're actually working. So this learning system idea comes into health systems that are actually wired to conduct their work in very different ways. So the prevailing way in which health systems do their work, in fact, looks very different. The typical approach when a problem is detected, as shown in the top left there, is that the problem is thrown to management. The problem is thrown to management or even higher up. We have a problem, we need to solve it, let's come up with a solution. So we go into an intensive design process. These could be annual or quarterly, or they could be reactive to something that may have happened. A solution is then established, which is then sent out to the front line to implement. But if you think about what is likely to happen, the first thing that a solution will encounter is real life. And real life will probably issue some harsh lessons, which is that it may well not work. Unfortunately, in this typical approach, our only way of knowing whether the solution is working or not is through some kind of inspection or audit process, which will happen only every now and again. So the typical audits that happen quarterly or even yearly, in some cases like the SARA or other systems, may happen even every 3 years. So we have limited opportunities to bring that learning back into our overarching designs. A different way would be when one encounters the same problem, would be to develop a theory as to how the solution might be derived, and take that pretty rapidly to the front line for testing. So many of you, and Dr. Mbewe showed the intensive consultative approach that is now being adopted in learning systems, where the problems really go to the places where the solutions are likely to be found, which is in the front line. Some basic skills are then used to analyze the system, come up with some ideas, and then the exciting part is that you can actually start testing it immediately, get some answers as to whether your solutions are working, and then develop some standard work which can be implemented and followed into the future. So this is the new way of doing things, and that is essentially what a learning health system is. A learning health system really is just a system that's able to look deeply within itself, and has the mechanisms and the culture. So we've heard about mechanisms, 5S, CQI, TQC, all the other acronyms that speak to the methodology and the mechanisms, the infrastructure, the people, the capabilities. But the essential other piece, at least the other 50%, is the culture, the openness, the transparency, the enablement to allow learning to happen. And for a complex health system like the one we just heard from Malawi to really thrive, you need both. The four elements that are outlined here are simply the inputs. We do need science, informatics, and we need a culture that is all aligned. These components have to come together. We have to have a system that can survey and harvest best practices, that pull those best practices into our delivery process. And essentially, families and patients need to be active participants. We can't pay lip service to it. And Dr. Mbewe made a fantastic point, which is that the typical patient satisfaction survey is not going to give you the answer. We need patients and families to be co-producing, co-designing these systems in order to be able to truly take their views into account. And then finally, we have to have a mechanism for capturing this new knowledge and designing it back into our systems. Nothing has shaken us more than the COVID epidemic, and what we see is that systems that are able to adapt and learn have in fact done very much better than systems that depend on rigid command and control systems for responding to the shock. So the shock of the pandemic has really tested health systems in a way we've never seen before, and we're seeing around the world that systems that have these that are able to learn on the fly are able to adapt much better and deal much better with the challenges of COVID. And I think the lesson from this is that the essential domain of resiliency, the quality that comes from being responsive, is the factor that will lead to organizations being more resilient and more sustainable in the long run. So this is a really important investment for health systems to be able to develop learning systems that can quickly be aware of the situation, pull ideas from the front line, devolve responsibilities, allow testing and experimentation to happen in order to be able to respond. So the question is, how do we take that framework that Soji showed us at the beginning and the lessons from our inquiry into country and turn them into the model that Dr. Mbewe just showed us, a really beautiful model of flexibly using different QI tools, using 5S for simple tasks at the front line, CQI for focused QI initiatives, and making sure, as Dr. Mbewe says, that both the clinical and the managerial parts are incorporated. We need different skills, but we need a way of putting them together. Dr. Mbewe also mentioned the WHO Maternal and Newborn Network. This is a grand global experiment. There are now 11 countries that are committed to using a learning pathway to dramatically improve the mortality for mothers and newborns, with an extraordinarily ambitious aim to cut in half deaths from mothers and newborns over a 5-year period. This was launched actually in Lilongwe in Malawi in 2017, and we've seen an extraordinary amount of activity in these 11 countries. And the reason they're able to function as a learning system is because they have these attributes. They have a common aim that binds them together. They're working together with a theory which they can test together. They're using these implementation methods that Dr. Mbewe mentioned, a variety of mixed methods. The essential component of keeping clinical and QI methods tightly together using the existing district structures. Measurement, absolutely. You cannot have situational awareness unless you've got a responsive measurement system. And finally, but probably most importantly, transparency. Being able to say, this is not a contest, this is not a judgment, this is really a journey that we're on together to try to save lives of mothers and newborns. So there is a roadmap that has been outlined for countries that deals with the crucial issue of leadership and planning. There is a set of activities in order to be able to actually implement the WHO, the new standards, both for mothers, newborns, and now in pediatrics. There's an intense amount of information that goes to district management to help them implement, oversee, and support these work. And very important, learning and accountability. How do we keep an eye on what's happening, not to judge it, but to help it, to help it succeed. This is an interesting exercise, and I just wanted to, you have 10 countries along the top, and I've covered their names because this is the trust that has been developed amongst these 10 countries is that they look at each other's data, but in a safe environment. So each one of these countries has been assessed, self-assessed as to how they're doing in leadership, in this action piece, and in this learning piece and accountability. And something very interesting from this visual that I will draw your attention to. You notice that the top half of the diagram, which is countries that have succeeded in the tasks for leadership and for initial activities, are mostly green. And in fact, they go. Each country goes from 2017 to 2000, sorry, to 2020, and you'll see progressive greenness. But look at the bottom there, all of the red. The hardest part of this that these countries are really finding are in two areas. One is learning, and the other one is scaling out of these little demonstrations that have been established. So the journey for learning is hard. But on the other hand, we do know that it's possible. This is an example from Bangladesh, from the Mamoni project, USAID Mamoni project, which IHI is closely involved in, and can show you across multiple districts, multiple facilities in a very large district, that you can get very high levels of reliability for the key processes of care. This is essential newborn care across 6 health facilities in one district in Bangladesh, a set of activities which are measured, and you only get a mark if you can do all 6 of these components. And you can see gradually over time, all of these facilities are able to perform at a very high level of reliability. And we would want to see all of these happen in order for mothers and newborns and children's lives to be saved. We have some information about what the remaining challenges are. I'm just putting them back up there. Morgan outlined them. around creating a culture of improvement, the most effective strategies and the key challenges, especially understanding this learning culture and deploying the management structures. We believe the weakest link in this learning system is the district management team, and they really need a lot of support in order to be able to switch from a inspection mind frame to a supportive mind frame. So I think that's basically what I wanted to say. And thank you so much again, Dr. Mbewe, for the work that you're doing in Malawi.
And thank you for bringing in such a global perspective about CQI models that are being used in many different countries, Pierre. We'll have a question for you on that in just a minute. But first, as we transition into our panel discussion, we do have a few questions that came in through the chat. We have Vivian, who is looking for Dr. Mbewe, if you could explain a little bit more about what the 5S activities in Malawi actually entail. Is that being used across all facilities? Is that being used in specific specialties? And how are teams approaching that? If you could add some more detail there, that would be helpful.
Thank you so much, Jesse, and thank you so much for that question. Yes, as a country, as you have seen on our model of improvement, 5 years we have put it as a foundation. Basically, as I indicated, that this is a model which we adapted from a Japanese model. Basically, it means the first 5 S is sorting. So in an environment or a work environment, we need to make sure we improve the work environment so that our staff, frontline staff, or anyone else is working in a very good environment. So you cannot work in an environment where things are filthy, untidy, unorganized. So we are looking at an environment where it's well sorted. So that's the first S. You sort out the environment, and those issues which are not necessary, you put them aside. Those items which are necessary, you keep them, and then that's the second S, setting. Those which are not necessary, you leave, you put them aside. Those who are necessary, keep them, and then you set them in a way that you know where you put. For example, in an emergency tray, you need to know which drug is put where and which supply is there, so that, for example, in an emergency, you can easily, quickly, and rush and get that supply and help a patient. And the shining is to make sure that the environment looks tidy. And the fourth S is about standardization. You have to make sure this is done routinely on daily basis, each and every time, and every staff in that department is part and parcel of that. And there are now issues of sustainability, the 5 S, to make sure that it's sustainable as a patch of the facility. And we rolled out nationally as a country, but we have got specific facilities where we are championing as a center of excellence in the country. About four facilities which we are putting more efforts as learning sites as a center of excellence. Thank you.
Thank you, Dr. Mbewe, for adding that extra detail around how 5S is being used. So our next question comes in. This one, I'll say, is for maybe Pierre to start, and then perhaps Dr. Mbewe adding some lessons from Malawi in there. But countries often struggle with different models for quality improvement. There are so many out there, from the model for improvement to Lean Six Sigma or Kaizen. What advice would you have for countries that are kind of struggling to unify their model for improvement, or are there space for all of them? So Pierre, I'll put that to you first, and then ask for others to address it as well.
Sure, thank you, Jesse, and it's such an important question. There's a lot of acronyms out there for all the different models. And what we try to do really is just to reduce it to the essential elements. First of all, everybody has some role to play in different parts of the organization, whether you're at the front line, whether you're a manager, or whether you are a planning leader. And systems thinking applies to everybody, and how you apply your systems thinking depends on whether you're mostly involved in quality planning, whether you're trying to do an improvement project, or whether you are trying to do your daily work and just to do it reliably, all of which require some reflection and learning. And so I think, and I completely sympathize with the question around all the array of different components that are required. But I think what our view about this is that there are very simple tasks, keeping an eye on things, standardizing things that need to happen every day at the front line. There are improvement projects, which are a few improvement projects which need to be led by managers and teams within the hospitals or facilities, or as Dr. Mbewe showed, that those happen at a sort of a slightly higher level. And then there are overarching quality planning activities that need to be done across the system. But all of those need to be connected. They cannot be, they all need to be part of one system. And so long as the tasks are well described for each level of the system, I think we can dispense with the acronyms and just describe for people. So here is a series of tasks, and here's a system of work at the front line. And likewise on the way up through the health system hierarchy. But I think it is the job of health systems to make sense of these. And what Soji showed at the beginning, which is the Duran framing of planning, improvement, and control, and which is part of assurance, is a really good way of saying who does what and what methods do we use to achieve that.
Thanks so much, Pierre. Dr. Mbewe, you had said early on in your presentation that Malawi falls back to the model for improvement, and you had also shown that pyramid graphic of CQI within Malawi. Anything to add there around how you sort of were able to unify the system around a consistent methodology?
I think we may have lost Dr. Mbewe. I don't see him on the panel screen. But
I would say, yes, I would jump in whilst we try to get Dr. Mbewe back. And I totally agree with the comments made by Pierre. I think what one observes is that in a number of the countries, there's a feeling that they have to choose one method over the other. And I think that the example from Malawi is very clear, that it depends on the level at which one wants to intervene. And they're deploying a variety of tools. I think it's also important to focus on the WHO framework that says that all of these interventions must be able to address 4 key things: the system environment. And I think that's where Malawi is deploying the 5S Kaizen tools to sort out the environment, to get it clean and tidy, and to help them to focus. Also talks about the fact that one needs to be able to use these methods to reduce harm. And then the third is to improve the clinical care. And I think this is where the model for improvement has enabled a number of managers and frontline practitioners to be able to focus on areas, to come up with ideas, to tackle issues around protocols and attitudinal issues and so on and so forth. And the last area has to do with interventions that engages communities and patients. So whatever the methods are that are being used, it is important to see it through these 4 lenses to be able to actually measure impact. And I'm hoping that Dr. Mbewe is back at this point.
Yes, I'm back.
Thank you. So Dr. Mbewe, and I think this might be the last question. We've been talking about selecting a model for continuous quality improvement, and it seems in Malawi you've been able to unify around that pyramid graphic you had shown and using the model for improvement. Any thoughts or lessons about trying to get to that unified model in Malawi?
Yes, quite true, Jesse. Initially, actually, we used to have different programs, different projects using different models. So we thought, I think we and in the end, it was more of project mode. So it was very difficult to harmonize what is happening here, what is happening in other area of the country. Then, as a country, then we decided, no, why can't we have a consensus meeting with all the stakeholders in the country and look at whatever model is being used by different institutions or organizations, and then agree on a harmonized model which we can all champion. That's when now we actually most of the models which were being used were focusing more on the patient care. For example, the continuous quality improvement using the PDSA, and some on the very minimal and on work environment like systems. So we said, no, I think we need really to combine these things because they seem to work together, because we need to make sure we are also tackling the system part of it as well as we are focused, because when we are focusing only on the care itself in an environment which is not suitable, we have faced quite a challenge in terms of moving forward. That's when we agreed on this model where we have now the 5S as the foundation to improve the work environment and the continuous quality improvement using the model for improvement and the PDSA. That's how I can respond based on our situation here.
Thank you. Thank you very much, Dr. Mbewe. So lots of tools in our quality improvement toolbox, and to really think about using plain language and the right tool for the job at different levels of the system, going back to what Pierre and Soji said around quality planning, improvement, and control. So we are almost running up against time. I'd like to thank our presenters and panelists for an excellent presentation and excellent discussion today. I do see that we were not able to get to all the questions that came in through the chat, but that is all right. We have another venue that we can continue this conversation in. If I could have Kayla move to the next slide. As part of LHSS's support towards universal health coverage for our USAID priority countries, we are also launching peer-to-peer learning exchanges in domains that are aligned with that NQPS framework that Soji had shared. So we will send out a link after the session today, and I'm also pasting this link into the chat area right now. You can click on this link to join a WhatsApp discussion group around continuous quality improvement within a learning health system. We're hoping that this provides a space to enable the sharing of experiences, successes, and challenges of developing, implementing, and sustaining NQPSs. This is for government stakeholders, technical contributors, NQPS development implementation partners, really anyone with interest around this topic who is actively working on it in their countries. So again, just click that link that was in the chat, or click the link that will go out in an email following today's meeting to get involved in the continuing conversation, and we'll be able to pick up on some of the great questions that came in the chat around data use and transparency, around quality improvement and the continuing pandemic. So again, a great opportunity to keep that conversation going. I'd like to close by thanking again all of our presenters and panelists, Dr. Soji Teti, Dr. Malangizo Mbewe, Dr. Pierre Barker, Morgan Stanzler. Thank you all so much for the work that you're doing and for being with us today to share that work. And lastly, thanks to everyone who joined us, and hope to see you in that peer-to-peer WhatsApp group for continuing conversation. As we close, also please complete the evaluation poll that'll just popped on your screen to help us improve our future offerings and understand the effectiveness of this webinar. So again, thank you everybody and have a great day.